So now we're actually, like Jackie was saying, right on time to introduce the next speaker, which is Professor Andrew Ryder. Dr. Ryder is professor at Concordia in the Department of Psychology, and he's a core member of the Center for Clinical Research in Health. His research focuses on the integration of clinical psychology, cultural psychology, and transcultural psychiatry in the context of two interrelated themes of cultural shaping of emotions and emotional disorders and acculturation processes and their implication for mental health in migrants. And today's presentation is about language, culture, and mental health towards more sensitive approaches.
Okay,
So,
very
Dr.
good.
Ryder?
Here I am. So I am going to share my screen. Here we go. Let's start the presentation. Oh, come on. Oh, over here. There we go. This is good? Everyone can see? Okay. Alors, je vais commencer un peu en français.
I'll start in French for a little bit. Thank you for giving me opportunity to speak to you today. I start with a summary, brief academic bio, then linguistics barriers and professional barriers for health, then the interactive onus of mental health, linguistically, culturally sensible therapy, and finally, the mutually beneficial implications.
One of the themes, of course, is I'm going to use myself as an example, talking about mental health and language. I suffer from social anxiety, but I only suffer from social anxiety in French. And so this is, of course, a recurring problem for a lot of people. It interferes with being able to seek the mental health care that they might want. And what I'm going to try to emphasize is how is sort of the central importance of language for mental health in particular, and the burden that puts on linguistic minorities. And this is, I was invited to give this talk. I'm really grateful to have this opportunity. I was invited to give this talk by Dialogue McGill, because for the last 10 years, and it was only when I got the invitation and I looked at my CV, I realized it's exactly 10 years that I have had funding from Dialogue McGill for various projects. I'm going to tell you in sort of a general overview about what I've been doing with Dialogue McGill support. And at the end, I'm going to reflect a little bit on the importance of that support for being able to pursue these questions. I'll begin, though, with a brief academic autobiography. It gives you a sense of how I got to do the work that I'm currently doing. So my story begins in the 1990s. I did a psychology degree at the University of Toronto, and I did my honors thesis on Chinese families and psychosis. And this was a real coincidence, right? Sometimes in an academic journey, one just has to take advantage of good luck. And I didn't even realize it was good luck at the time. I went to volunteer at the Center for Addiction and Mental Health. I asked if I could assist with a research project of some kind. I didn't know anything. And they literally, the volunteer coordinator reached into a box of recipe cards, pulled out a card, asked me my GPA, asked me if I was interested in culture. I intuited that if I said yes, she'd give me something to do. And so I said yes, and she gave me something to do. And that actually set me on the trajectory that I'm still following now. So it led me, first of all, to do this honors thesis on Chinese families and psychosis. But nowhere was there language. In that project, everything was done in English, and Chinese families who couldn't speak English just weren't eligible for the study. It takes a while for language to to make an appearance. I then did a master's in clinical psychology at the University of British Columbia, where I did a master's thesis on China acculturation. But because the thesis was conducted entirely with UBC undergraduate students, again, language didn't make much of an appearance. You have to be able to speak English to be at UBC. And so again, I didn't give a lot of thought to language, but increasingly was giving thought to culture. Then I did my PhD in clinical psychology. I remained at UBC, and I did a dissertation on depression in China. It was really only here that I started to encounter the challenge that language adds to cross-cultural work. I mean, I knew in the abstract, if someone had asked me, is language important? I would have said, yeah, sure, of course it's important. But I hadn't really had to engage with it much. But I collected half of my data in China, had to deal with translation, it's not like I knew Chinese. So, I mean, I learned a little bit, but I had to rely on a team. The previous speaker was talking a lot about the importance of teams and mentorship, and I couldn't agree more. I really had to rely on people to manage the linguistic aspects. And of course, one of the things that I started to realize is not just that you have to think about translation, but some things are harder to translate than others. And the material that is hardest to translate is precisely that material that psychologists are most interested in. Symptoms and emotions and complex subjective states. And so I started to think about what this meant for people. And I started thinking back to my masters and my Chinese migrants. Sure enough, there they were at UBC functioning as students, but I had the first inklings of questioning about what would it be like for a student like that to seek mental health services, given the much, much higher level of fluency that's required to do that well. I then did a clinical internship. Like all clinical psychology students, I had the opportunity to do 1 year at a hospital that could be done more or less anywhere in North America. And I ended up at Montefiore Medical Center, which is part of the Albert Einstein College of Medicine in New York City. And this Montefiore Hospital is in the Bronx. So this is a highly multicultural environment. There were many Spanish-speaking clients, but I don't speak Spanish either. And so there was a lot of negotiation around how these Spanish-speaking clients would share their distress and so on with me, a culturally different, ethnically different, and linguistically different speaker of the majority language. There was also a sort of a funny incident when I was an intern where in a unit, a different unit, a geriatric unit where I didn't even work, they were struggling to place a Haitian woman. They couldn't place her in a long-term care facility because they had to give a particular test called a mini mental status exam. And some kind of neurological event had wiped out her second language ability. So she could only speak French. And someone happened to hear this and said, wait a second, we have a Canadian on our internship program. Canadians speak French. And they came and talked to me. And I found this quite alarming because I grew up in Toronto and I just spent years in Vancouver. I think your estimates of my ability are a bit exaggerated. And they said, well, we don't have any choice. So I went home that night and I learned how to do the mini mental status exam in almost phonetically pronounced French. I hadn't forgotten everything, but it was far from fluid. But it ended up being a big contribution. I came in, I fumbled my way through. She had this massive positive reaction because, wow, someone is speaking to me in my language. I was barely even speaking it, but still. And she got the services she needed. So I thought, wow, if I hadn't randomly been there with my even broken French at the time, what on earth would they have done? So this story kind of lingered in my mind when I went on to my job, which is at, as Carmen said, the Center for Clinical Research and Health and the Department of Psychology at Concordia University, where I direct the Culture, Health, and Personality Lab. And I want to give a special mention here to my colleague and friend, Norman Segalowitz, who actually introduced me to Dialogue McGill, or went by different name at this point. And he was he is a psycholinguist, studies language. And when I was being hired, I had a chance to meet with him for about 20 minutes. And I still remember the conversation we had. It was me saying, as a cultural psychologist, why don't we spend more time in cultural psychology learning about language, really learning about it in detail? And he said he feels the same way about psycholinguistics, hardly ever speaks about language in a cultural context. It's almost language as a technical accomplishment or something like this. And we've sort of been having this conversation ever since. I've now been at Concordia for 17 years, and we're still working together to think of different ways to combine cultural and linguistic perspectives, and increasingly applying this to mental health. I also have a cross appointment in the Department of Psychiatry at McGill, specifically in the Division of Social and Transcultural Psychiatry. And I work inside the Culture and Mental Health Research Unit, which is housed at the Jewish General Hospital. And that's directed by Lawrence Kiermaier. But I'm going to give a special mention here to Eric Jarvis. He has also been funded by Dialogue McGill on a few occasions, or by its predecessor. And I have sometimes been a co-investigator on his projects. I'm not going to talk about those projects here because someday he might want to do so himself, but just to acknowledge that quite the number of people who have sort of brought me into this, this particular world. Okay, now I want to talk about my research. I want to do so in 3 phases. And the first phase this is the phase of trying to find my feet, helping Norman with some of his projects, and trying to think about what my role might be as someone who is not used to thinking about Anglophones as a minority group, who's not used to thinking about language as anything other than a demographic tick box on a questionnaire. So it was really a chance for me to think more carefully about language. And I took as my starting point this paper by Norman, which he did 10 years ago. And this was designed as a kind of a manifesto for the, I mean, at the time, I think it was called HCOM, Healthcare Access for Linguistic Minorities. So this was toward a research agenda. It was targeted at the language sciences. It was published in Canadian Modern Language Review. So I'll briefly describe a few projects that happened in this early stage. The first thing that I did was trying to build an archive of commonly used language and culture related self-report questionnaires in English and French to really try to consolidate the tools that we had available in order to share them with others, build a growing repository of instruments that we could use in both languages that would help us do our research, and have some examples here of tools we refined in this way, and in some cases also retooling them semantically so that they'd be more effective for use with linguistic minorities. And so, for example, language background questionnaire, the Vancouver Index of Acculturation, which I developed for my master's thesis, acculturation stress inventory, and several others. The next step was to develop some measures that were specific to participation in language communities. So starting from the ground up, not just adapting and translating. Now, in some cases, we started with tools that were developed to assess participation in cultural communities, but in this case, we had to make some more radical changes. Really trying to get at what it's like to be someone living in a linguistic minority situation, which at that time was something I was still trying to get my head around. Of course, we had versions available in English and French. One example of such a tool was the acculturation identity matrix. This was based on a technique called identity structure analysis, which is actually really kind of a sophisticated technique. You can do quite a lot of different things with it. It's a bit different from normal psychological test development in that you are crossing constructs that you choose as a researcher with entities that you also choose as a researcher. So we took 12 bipolar constructs, and in this case, we took common personality traits, and we chose 12 entities. And we chose these entities around sort of thinking about how the self fits into different linguistic communities, and really emphasizing the Quebec case of being an Anglophone or a Francophone that has to, at some level in Montreal, think about both English and French. So you might rate, you talk about yourself when speaking English. How am I when I speak English? I am confident. How am I when I speak French? Not so confident, right? There's some shifts happen there. I don't feel so confident. I don't feel so competent. Maybe even a little less friendly. It's hard to say. How I think I'm seen by fluent English speakers, how I think I'm seen by fluent French speakers. And we had 12 of those. You cross the constructs with the entities, it gives you 144 items. So for every entity, for example, who I am when I'm speaking English, I would rate that aspect of myself on all 12 personality traits. How I think Francophones see me when I'm speaking French, I would rate again with the 12 traits. And we found this to be quite an interesting tool. One of the things that I like about it is because you get a lot of information about an individual person. It turns out to have quite a bit of validity when you use it with clients. So it's not just a tool that you have to use with big samples of 100 or 200 people. It's a tool that works decently well when you give it to one person. And I found that clinically can have really interesting conversations with people about how they fit into the linguistic duality of Montreal. Second example of a tool that we've developed is the multilingual assessment of preferences and identities, the MAP ID. And one of the things that we like about the MAP ID is it's not limited to 2 languages. You really can get at all the languages that people speak. Montreal is, I've been told, one of the most, maybe the most trilingual cities in the world. Lots of people who speak English and French and 1 or more heritage languages. And we didn't want to limit participants necessarily to only being able to talk about English and French. So in the MAP ID, you have 3 phases. You start with self-reported fluency in different languages, and then you ask for concrete examples across different domains. You get questions about listing favorite books that you've read over the last year, favorite foods that are a regular part of your weekly diet, and so on. So you get a whole set of different examples. Then, and this is done online, you feed these examples back to the participant, but you match each example to the primary language that they associate with that. So for example, if I spoke English, French, and Russian, and I liked War and Peace, I might associate War and Peace with my Russian linguistic identity. Well, unfortunately, as much as I like War and Peace, I don't read Russian. So the fact that I have read War and Peace that's an example of me being an English reader because I've read it in English translation. So that's my association, the language I need to do this. I would do the same with friends and reporting the languages that I speak with different people in my social network. And it allows people to, you sort of get a sense of how people use language in daily life. Maybe they know the language, but do they use it to speak to people? Do they know people who can speak it? And of course, for an immigrant, this is a big challenge. Trying to learn English or trying to learn French, you don't have the skill to have a relationship with people, but you need to have a relationship with people to really learn how to speak the language properly. So there's a kind of catch-22 that can be challenging for migrants in the early stages. Then we did a study that was partially funded by Dialogue McGill. The Canadian side of it was, the Australian side by the Australian Research Council, and we were able to publish this one. So this was a study, it was primarily done by Norman Segalowitz, but I assisted on it as well. And what we were trying to do was get at medical communication about prognosis. And when you talk about prognosis, you use adjectives of certainty and doubt. So for example, if you get told you might have a terminal condition, you definitely have a terminal condition, you supposedly have a terminal condition, you're going to have very different reactions to these different sentences. And the question is, are these words get used a lot in medical communication? You're purportedly going to need this test. You're definitely going to need this test. You might need this test, and so on. And they're words that can be tricky for people in their second language. So we thought maybe this is some area where medical miscommunication might be going on. It's kind of a complicated study methodologically, and for the purposes of this talk, I'm more interested that you have the general idea of what we were getting at rather than the specific details. We used some techniques that I've listed here. The basic idea, though, is we give people sentences that they're sort of sentences that might occur in a healthcare setting, and we would insert different adjectives to nuance the sentences in different ways. We present pairs of sentences and get people to rate the similarity that they perceived between the sentences. And so doing this research, we found, for example, that within Australia and Canada, there is consensus. There's actually difference between the two contexts. So even English speakers in Australia and English speakers in Canada understand these words slightly differently. That means that this technique allows us to detect which words cause the most confusion, which is useful. If you're comparing multiple language communities, you can pinpoint words that are confusing, and you can pinpoint what the differences are between those communities. And we've done some pilot studies following up where instead of looking at English speakers in two countries, we're looking at English Anglophones who speak French as their second language and Francophones who speak French as their first language, and vice versa, and try to get sort of what is the cost of trying to do this in your second language. We also did a pilot study. This is not published. It wasn't big enough. It was done for a student's honors thesis student, but you'll see a few slides from now, it becomes the inspiration of actually pretty important clinical study that is still ongoing. This is a pilot study of undergraduates. And what we wanted to do was get people into something that was closer to a real live setting. People rating the similarities and differences in adjectives, it's not super realistic. In this case, what we did is we had them come into the lab, and we had graduate students who are in their training in clinical psychology, but we could do something that you can't really do with patients, which is we would have these English favoring bilingual undergraduates and French favoring bilingual undergraduates, and you get both at Concordia. And then the bilingual Anglophone graduate students would interview them on two topics relevant to student well-being. So it's not asking about their personal emotional struggles, but it is asking more generally about how they cope with exam stress and how they find making friends on campus is. So, sort of adjacent to the kinds of things that might come up in psychotherapy. And we randomize which topic is going to be talked about in English and which one is going to be talked about in French. So we end up with this crossover design, and people have to switch halfway through. They get a little break, at a glass of water, and then they do the second topic in the other language. And so some people are switching from their first to their second language, and some are going vice versa. And the bilingual graduate students, we've assessed their language ability, and they could all do it in both languages, but they also have varying ability and so on. We did quite a lot with this data. It's quite interesting. Certainly, in terms of subjective reporting, Both the interviewer and the interviewee reported different experiences depending on language. Certainly didn't surprise us that this is more difficult in the case of a language mismatch. People found this harder to do when going across a linguistic divide, even when the interviewed was allowed to speak in their first language. But what was nice is we can actually found some ways of displaying this graphically for each participant in the study. And I'll just show you an example. On this graph, basically what happens is the diagonal line is the conversation unfolding, the back and forth dialogue. And every time language is echoed, it appears in this sort of space below the triangle. So wherever you see a big pink or blue square, it's where one person is adopting language that the other person had already used. So using their expressions, echoing their language. Imagine asking a follow-up question which incorporates the words that the speaker originally used. Things that you think, well, that's pretty normal, right? If you're decent in having a conversation, that's going to naturally occur. And sure enough, it does naturally occur. So there's a concordant example on the left side. Both people are speaking the language that they're most comfortable with, and you get lots of echoing. The discordant is on the other side, and there is much less. This is, with small samples, this is analyzed visually, but we think it's a very promising method for actually picking up where conversations are proceeding more or less fluidly. And one of the nice things about this technique, it relies on online dictionaries and other things, but there's a good corpus of words in both English and French. So we've been able to use this tool for English-French research. The tool was originally developed in Australia. It's called Discursus. And it was because of our collaboration with that Australian team that we got exposed to this a novel way of thinking about things. Okay, I'm going to switch now to talk more about the interactive burden of mental health in particular. Up to this point, it hasn't been particularly mental health focused. There's a pun in here. It's an interactive burden in that mental health interventions are highly interactive. Right? There's an interaction between the clinician and the client. But it's also an interaction, as I'm going to demonstrate, there is a statistical interaction such that second language communication about mental health is uniquely difficult. I'm going to start with a favorite quotation from Lucien Bouchard, who said, that was a long time ago now, 25 years ago, am I counting that right? 25 years ago, he said, when you go to the hospital and you're in pain, you may need a blood test, but you certainly don't need a language test. Actually, I think it's a pretty thoughtful comment, especially given his overall political perspective. And I think it's a totally fair thing to say. I would add to that if you go to the psychologist and you're in mental pain, you definitely don't need a language test. It's going to be hard enough to talk about this in your first language, and yet many people don't have that choice. So they're well established that minority language communities, like other ethnocultural minorities, are less likely to use health services in their second language, especially less likely to use mental health services. But what is the source of reluctance to seek healthcare in a second language? Is it something obvious, like, oh, they just don't speak the language fluently enough? Or is it second language communication anxiety? Like they could speak it, but it makes them nervous to do so, and so they don't want to talk to a highly educated professional? Or is it just simply that people are anxious around health? They wouldn't want to talk about health in any language. They're just reluctant to seek healthcare. Or is there something about speaking about health in one's second language specifically? So you could take someone who's quite comfortable in their second language and who's quite comfortable talking about health, but they don't want to talk about their health specifically in their second language specifically. And that's actually what we have been repeatedly finding in our data. First, we did a study of social networks of migrants in Montreal with English as their first official language. But we were interested in who talks to whom about health and across what language lines do they do so. These are 100 migrant university students. And we found that more integrated networks predicted less communication anxiety. So if you knew, and I'm still trying to puzzle through what this means, if you know individual people in your second language community, it doesn't help you feel more comfortable talking about your health. But if you know an integrated network, if you know people in your second language who also know each other, like you're actually part of a community of second language of people, like if you move to Quebec and you know a bunch of francophones who you speak to in French, but who also speak to each other in French, this seems to help somehow. It predicts less communication anxiety in general and also about health. And we have some thoughts on why this might be. And this was really just a first look at the problem. Much more exciting, I think, is this study that we were able to publish in the journal Health Communication. This is 314 ethnocultural minority adults. They had to have English as their first official language. They might have some other language as their actual first language. And they had to have some aptitude in French. And they came from all over Quebec. We did this in using an online format. And we looked at L2 communication anxiety in general, but then we modified the items so that they'd make specific reference to physical health settings and mental health settings. We were interested in, again, in reluctance to seek healthcare. And what we found was an interaction, that L2 communication anxiety specific to health is what predicts reluctance to seek healthcare, that there's something about having to talk about health in your second language that's causing particular problems. So it's more than just health, and it's more than just second language. And then we found this effect was modest. It was interesting, but modest when it came to physical health. It's actually quite strong when it comes to mental health. There's something uniquely difficult about this. And of course, I'm a clinical psychologist and I'm licensed clinical psychologist in Quebec. I thought, well, I've got to follow this up. This is when I switched from being someone working with Norman Segalowitz on these questions with someone who is enthusiastically writing to Dialogue McGill with new project ideas. This is a sort of tipping point here. Like there's something here I can do as a clinical psychologist. So we did a replication study in Chinese migrants in Quebec, but all who prefer to speak English as their second language, but have some French capacity. In some cases, some quite good French capacity. And again, we found this effect, reluctance to seek healthcare, going beyond health anxiety and L2 communication anxiety. And again, that this was especially pronounced for mental health. Right around this time, we had a serendipitous finding from another project. This was not a Dialogue McGill project. It was just an internal Concordia seed money funded project. And we were doing qualitative interviews with practicing clinical psychologists in Quebec. And a lot of it is just about the workplace stress and burden that's on them. But, you know, because of my interests, I had a module at the end where I was asking them questions about multicultural competence. How had they been trained? How ready did they feel? This kind of thing for working in a multicultural milieu. And more than one of these participants spontaneously asked, what about multilingual competence? They actually, I didn't even ask about multilingual competence. They came out and said, like, what worries them is someone who would prefer French, but they're more comfortable in English, someone who would prefer English, but they're more comfortable in French, someone who would probably prefer Arabic, can handle French, but you're more comfortable in English, someone where you're good enough at French and you switch over, but then you feel like you're missing the vocabulary for the specific function of being a psychologist. This theme just kept coming up over and over. And I thought, okay, maybe we're onto something here. And that leads me to what I'm most excited about now, which is linguistically and culturally sensitive therapy. So why is mental health care particularly difficult to seek in one's second language? Well, So why mental health care? Well, the tricky thing with mental health care is language is important. It's always important, right? And people can talk eloquently about the physical health problems that can occur when physicians and patients can't communicate effectively with each other. All that is true. And I think mental health ups the ante further. Assessment and diagnosis require the clinician to understand the client's subjective state. I mean, there are also external cues and other things, but it's an awful lot of questioning to the person about what it is like to be them. And this is largely communicated by language. You ask questions, they respond, you push further, they respond more. You're trying to find the right idiom, the right metaphor, the right way of capturing an inner experience. And you're doing so when you're quite distressed. And you might also be shy and you might be uncomfortable talking about this topic. And then if you are successfully diagnosed, let's say with anxiety or depression, one of the treatments that might be recommended to you that actually has a high degree of effectiveness is a primarily linguistic treatment. So great, now we have diagnosed you with depression. Now we're going to recommend 16 sessions of psychotherapy, let's say, for starters. And in a way, if you're in a language mismatch situation, this becomes incredibly complicated. So it's not just misunderstanding the instruction for home care or for your prescription. You can ask again, I'm sorry, I didn't understand. Can you repeat that? And hopefully a warm, competent physician will try to bridge that gap. In psychotherapy, moments come and they're lost just like that. I don't think I could yet do psychotherapy in French for that exact reason. I could do assessments in French. I can have casual conversations in French with some disfluencies here and there. Psychotherapy is a whole other ballgame. I remember a Francophone Quebecois clinical psychology student at UBC with me, spoke English fluently. He probably made one mistake a week, as far as I could tell. After doing psychotherapy in particular, he'd say, oh my goodness, I lost half my English. That was really stressful. He felt like it pushed him to another level of linguistic requirements. And that stayed with me. I thought that was really interesting. So there's meta-analytic data on psychotherapy for minority clients in the US that I think is really interesting. People used to think that what you need is to match people so that they have a therapist from the same background. But this actually doesn't improve outcomes. People moderately prefer it, but it doesn't make the therapy work any better. Culturally adapting the therapy does improve outcomes. And of course, my primary interest is the cultural side of things. And so that's kind of reassuring that all this work on cultural adaptation doesn't actually help. But the other thing that these meta-analyses keep saying is that if you can give therapy in the client's first language, this also improves outcomes. And those are two independent effects. So if you can be culturally sensitive and you can be linguistically competent, then those are where the best outcomes are going to come from. Quick aside to say that all this comes from the perspective of cultural clinical psychology, which is based on understanding and helping the person in context. And that's the lens I bring to this, including the language research. It's not the person as a collection of traits and attributes and memories that are abstracted from the larger context, but it's also not studying each culture as a distinct group that have meanings and practices separate from the lives of particular people. The best example I can think of is from the cultural psychiatrist Arthur Kleinman. He asked the question, as a Jewish man himself, do Jews eat pork? And he points out that if you reduce everything to the individual person, you'll say some Jews do and some Jews don't. And Kleinman himself says, I am a Jew who eats pork. There are other Jews who don't eat pork. So maybe it's just an individual difference. But then, of course, if you ask a lot of people, they'll say, of course, Jews don't eat pork. Look at their customs, look at the traditions, look at the Talmud, look at the Jewish law. And what Kleinman says is that neither of these answers is satisfying. You have to look at the individual difference. You have an individual client, an individual person who might or might not eat pork. but it is different to be a Jewish person who chooses to eat pork than it is to be a Chinese person who chooses to eat pork. And if you want to understand that difference, you have to know something about the individual person and about the context in which they live. We can't reduce people to their contexts. All Chinese people are the same and do this. All Jewish people are the same and do that. But we also can't focus on people and ignore the contexts in which they live. So that's the perspective we're coming at here. And in that view, culture is not simply a matter of which cultural group you're classified under. We understand culture as networks of meaning that are both in the head, they're cognitive, and also networks of practice in the world, ways of speaking, of acting, behaving, rituals, institutions, and so on. And not all that information is linguistic, but an awful lot of it is. Take, for example, the complaint, I have butterflies in my stomach. I might have said that 5 minutes before starting this talk. I have butterflies in my stomach. Now, if someone misunderstands me linguistically, and they think I say, I have butter flying in my stomach, and they imagine sticks of butter flying through my stomach, they have misheard me. They don't know the word butterfly. Some kind of linguistic misunderstanding has taken place. But maybe they know exactly what I said. They know that I said I have butterflies in my stomach, but they don't know this is a metaphor for anxiety. If they're a clinician, they might grow concerned that I have the false, even delusional belief that I have butterflies in my stomach. I mean, it sounds like a silly example, but in other directions, mistakes like this get made all the time. People in West Africa sometimes say that they have bugs crawling in their head to mean that they have a lot of thoughts that they're worried about. And some of them have been misdiagnosed as having psychotic beliefs about the contents of their head. So we need to understand language and culture together. There's both the technical feat of understanding the words someone is saying, but also placing those words within a language community that can mean different things. Now, there are two clinical problems with this approach. The first is that we're never going to develop standardized treatment protocols for every local socio-moral world. And we will never be able to deliver therapy in the first language of every client. So what we actually need is a generalizable approach that acknowledges these limitations. And that's what I've been working on with a bunch of funding sources, especially including Dialogue McGill. The most recently completed study, we had 18 participant clients seeking help for anxiety or depression. They had various degrees of cultural and linguistic mismatch. We had a bunch of self-report measures, including a lot of tools that we had developed with support. They then underwent 1 hour of a culturally informed diagnostic interview and 4 hours of a culturally informed illness narrative. So they tell us in detail about their cultural worlds, possibly doing so in their second language or in the therapist's second language. We got qualitative evidence that this approach generates information that could prove useful in therapy. So, for example, personal beliefs, common expressions, metaphors, and so on. Also local beliefs, so beliefs that they didn't hold, but their families or communities did. And we found that culturally trained clinicians can lessen the risk of linguistic or cultural errors, or if they make an error, we can train them to be better at detecting them and repairing them. We also have got preliminary quantitative evidence that this approach is therapeutic in itself, which is kind of a nice discovery. Turns out that 4 or 5 hours of being carefully listened to and having a chance to really share your larger context, that participant clients really appreciate this. They appreciate the time taken by clinicians. It boosts therapeutic alliance and rapport. And then that got us interested in whether that might improve the efficacy of treatment downstream. Because one finding that comes up all the time is that psychotherapy, when you're well connected to your therapist, is much more effective. And so that leads us to some of the work we're doing now. We got interested in to what extent early attention to linguistic cultural context benefits standard treatments once you start giving them. For example, is it good to be able to use the client's language? It's not that you're speaking the client's language, but you're using some of their expressions, right? You're meeting them part way. You're caring about their linguistic and cultural world. And also we were interested in further studying the benefits of this enhanced therapeutic alliance, as this is a strong predictor of good outcomes. So our current study that is being funded, just getting underway, we'll have 12 additional participant clients seeking help for anxiety or depression, again with various degrees of linguistic cultural mismatch. And then the same initial sessions of really trying to get a sense of their world, but then followed by 12 sessions of process-oriented CBT. And again, we'll study this qualitatively and quantitatively. It sounds like a small sample size, but we're using special statistical techniques that allow us to actually study the outcomes for each person individually. So it's almost like a series of 12 case studies where there's different degrees of linguistic and cultural mismatch. Final point, our student clinicians for this study have all been trained in my lab over several years, and they bring that training to what they're doing, but we're aware that most clinicians don't get this training. Quebec psychologists, as I said, feel underprepared for cross-linguistic and cross-cultural clinical work. So we have another Dialogue McGill funded study also getting underway that explores clinical psychology training at Concordia and McGill. We have a lot of questions for students and recent graduates. One of them, just to give you an idea, is does lack of support for learning French lead multilingual clinicians to leave Quebec? And so one sense I have in my lab and other of my colleagues at Concordia and McGill have is that we lose people who do not have the French to qualify as a psychologist in Quebec, but we especially lose people who might be migrants to Canada. They might be Chinese migrants to Canada who learned English in Vancouver or Toronto. Then they've come to Concordia for graduate school. They have this excellent multilingual ability. I have a student who knows English, Cantonese, and Mandarin, but the Ordre des Psychologues du Québec expected her to also pick up French while a clinical psychology graduate student. Now, I actually strongly support the idea that clinical psychologists have to be able to speak French. I think it's actually really important for the profession, but I wonder, are we not being sufficiently flexible with how much time we give people to pass the exam? Could the universities offer more support so it's actually viable for people who have this rich cultural and linguistic ability to actually stay in Quebec, contributing their new French skills, their English mastery, and the one or more other heritage languages that they're also fluent in, so that we could have a proper core of culturally and linguistically prepared psychologists in Quebec. To conclude, I think there are some implications that are mutually beneficial. I hope this work benefits the larger Dialogue McGill project. I have 4 ideas of how this might be. I think our work exemplifies the idea that there is a cultural diversity of Anglophones. It's not just one community. That the interrelation of language and culture that needs more attention. That mental health in particular ought to be prioritized. And I was glad to see that Dialogue McGill had a specific competition about this. And that there's a need for methodological diversity to study these kinds of questions. So I want to make those as sort of 4 take-home messages. I also want to express my appreciation to Dialogue McGill. A lot of this research simply wouldn't be possible. The rapid turnaround allows for rapid progress. So we can be very reactive. We detect something, sometimes even a serendipitous finding. We can run with it. And this is actually really important to being able to develop, especially this clinical research on the fly, rather than taking years to build up a large CIHR application. The small but frequent financial infusions are perfectly scaled to the kind of work we want to do. CIHR grant, I mean, it's sort of ironic. They will fund these big projects. When I apply to them, they say, you don't have enough data to justify this big project you're asking for. If I ask for funding for a small project, they say I'm not being ambitious enough. So I think what is happening here is we're getting this access to a way of developing the plausibility of our treatment. And then we would turn to CIHR to go from plausibility to ironclad evidence that it's the best way to proceed. I really appreciate that Dialogue McGill allows for many different ways to conduct research and many different ways to show contributions, not just publications, but also talks, workshops, online resources, treatment manuals, and so on. And finally, I want to acknowledge that my academic identity has shifted. I'm now starting to see myself as a language and culture research in mental health, and not just a cultural researcher. And that is due to the 10 years that I have now been working with Dialogue McGill funding and funding from the HCOM predecessor. Merci beaucoup à mes co-chercheurs, Norman Segalowitz.
Thank you very much to my co-researchers, Norman Segalowitz, Eric Jarvis, Natalie Din, and Irv McGill, and my students, Ji Chang, Momoka Sunohara, Dantao, Anna Voloshin, Yu Zhao, each student doing their own project with Dialogue McGill as well. And thank you to everyone.
Super. Thank you so much, Dr. Ryder. This was very informative. We do have some, we'll do it quickly. So we have a few comments and questions. So one comment is your depiction of butterflies in the stomach. So someone says, we have an expression in French that says mal au cœur, which really has nothing to do with the heart. It's just that you're nauseous. And so it's another example of a expression that someone would use. And if we take it literally, it would not convey what it actually means. To have mal au cœur is to have nausea, even though the heart is not involved.
That's a great example. Yeah, I mean, language is full of these things, and we take them for granted because no one would imagine a first language speaker just knows what it means. Like they deeply know what it means.
Exactly.
Yeah.
A second, a question was from Matthew Monroe. Do you have, they say, Andrew, your work directly supports our local initiatives. Do you have abstracts we could reference for some of these studies?
In some cases, yes. And I'd actually be really interested in maybe we could have a conversation about
with Matthew.
I mean, yeah, exactly. Because okay. Yes, I'd be happy.
Maybe we'll connect you to Jackie. You want to connect Matthew to Dr. Ryder? That way they can continue this conversation. The other thing that I was thinking, I mean, we got a lot of amazing work, very interesting. Also, I thought it would be great to compare your results with the students with those of Tyler Brown to see what are these, because it seems that there's connecting variables that you could compare with Tyler when he presented on retention of graduating students at McGill University. So that could be an
that would be really interesting. I'd be happy to be in touch with Tyler as well. I think that sounds great.
Great. So I think you also brought our attention to very positive concepts. You know, sometimes in mental health or other field, we have negative concepts, but you brought, you know, this notion of concordance in communication, you know, like this fluidity that seems to be promising. And, you know, I think the conference is a great example of concordance. We've been going back and forth, French, English. I don't know how easy it's been for the professional translator on the conference to deal with us moving back and forth from both languages, but it sure shows that there is definitely concordance in communication. The second concept you talked about is integrated networks, which I think has a lot of potential for further work. And the last one is multilingual competence. So we took note of that and really would, you know, support more work in this area because they're very promising concepts that are not well known in the literature, which brings me to tomorrow's talk, which will be with from Dr. Kestner, who will talk about collaborative autonomy. So I think there's going to be a lot of parallels between what you've mentioned today in your talk and what Dr. Kestner is going to present tomorrow at the closing.
Yeah, I suspect there would be, and he's a psychologist as well.
Exactly.
I know him a bit,
that's going to be very, very great. So thank you again. We're going to move on to our next presenter, actually our last presenter. So thank you. So happy to hear your work.
Good. Thanks so much.
Thank you.